As students, you know our mission. We exist to improve lives in our global community by educating diverse groups of highly competent and compassionate health professionals. What you may not be as aware of is that in our vision for the future, there are 4 vision statements. One is about educational excellence and all that we do in teaching and learning. One is about our focus on research and improving new knowledge and the scholarship that goes along with that. Our third vision is about our clinical experiences for our students and trainees, and also our clinic and the services that we offer there. The fourth area, which is what I want to talk just a brief minute about, is our focus on health policy advocacy and our engagement in the community. So the series that you're about to begin today really connects us to that fourth vision statement. So we welcome you to be a part of a very focused effort to educate and raise awareness about topics that you as students have decided are important for you and your training, but also important for community members that might come and be a part of this. So to kick off this academic year, our student groups organized a series of lectures, working with Sue Huppert, our Chief External Government Affairs Officer, to bring issues and individuals to our campus on topics that you wanted to hear more about. My compliments to our student leaders as they worked over the summer in extending invitations to several individuals, and I believe they created an excellent series of topics that would be pertinent to your training and just the edification of individuals who are aspiring for careers in the health profession. So I want to thank you all for being here. I want to thank our students involved in this, and I'll now bring Amanda Buck up now to introduce our speaker. Thank you all for coming.
Hi, everyone. Thank you for coming. My name is Amanda Buck. I think I know most of you, but for those of you who don't know me, I'm the president for the American Medical Student Association. And working with Sue and also SGA, we've put together a whole series around politics and medicine. We've been working since the spring on trying to put this together, with the primary goal being to help educate students on policies that are going to impact provider care delivery, patient access to care, and then also reimbursement. So we wanted to be able to bring this series to you guys so that you can feel better informed to advocate for those issues, especially as you go out into the healthcare realm as future providers. One of the important topics in this realm is the recent privatization of Medicaid. So we're pleased when Ms. Stiers agreed to come to DMU and speak, as she's the Medicaid Director for Iowa. And I understand she's been a very good friend to DMU regarding legislative issues over the years, so we're very pleased to welcome her here today. Mikki Stiers began her duties as Medicaid Director on May 27th in 2015. She brings to Medicaid more than 33 years of experience in the healthcare industry. Prior to being appointed Medicaid Director, Stiers worked with hospital startup, restructuring development, and growth in a number of executive positions. Most recently, Stiers was the senior executive responsible for external rotations at Broadlawn Medical Center. This role included building an external network of business leaders and legislators to support the hospital's operations. She helped develop the hospital's strategic plan and worked regularly with local and national lawmakers on policy issues and with media on topics of public interest. Stiers holds a master's degree in health administration from the University of Colorado, a bachelor's of science in occupational therapy from Colorado State, and serves on a number of local and national boards. In her work at Iowa Medicaid, Stiers manages Iowa's $4.2 billion Medicaid program. Stiers is responsible for providing day-to-day leadership and direction of the Iowa Medicaid enterprise. The Iowa Medicaid enterprise processes over 46 million medical claims per year and contracts with over 38,000 Iowa healthcare providers. Iowa Medicaid serves over 560,000 Iowans, and Iowa Medicaid is currently undertaking a variety of new endeavors, including implementation of the Iowa High Quality Healthcare Initiative, which is the transition to managed care, the State Innovation Model Grant, implementation of the Affordable Care Act, including the operation of the new Iowa Health and Wellness Plan, along with other projects. In addition, Stiers is a believer in strengthening partnerships in the delivery of healthcare and increasing awareness among policymakers about Medicaid programs. It's my pleasure to welcome Ms. Stiers to DMU.
So good afternoon, and thank you. And thank you for inviting us, because I think this is a really hot topic. If you haven't been reading the newspaper, I'm sure you know it is a hot topic. But we're going to walk back just a little bit for you in terms of where we were at. Somebody just asked me, is this my dream job? You betcha. I mean, this is amazing to be able to make differences in members' lives and enhance access. And you'll see where the vision is headed with this initiative. Would I tell you to start a job in a year and do this much in a year? Maybe not so much today, but normally it's pretty fun. So you've got to be excited to be able to make these changes. So when you look at this, this actually started with the Affordable Care Act for us. Many of you know the Iowa Health and Wellness Plan was the governor's initiative for the expansion of Medicaid. Many states did Medicaid expansion. We actually did what's called the Iowa Health and Wellness Plan. That allowed members between the ages of 19 and 64 to receive health care. They actually, up until this year, went to the marketplace and actually purchased insurance on that marketplace. That actually expanded Medicaid, because Medicaid right now traditionally only provides coverage for individuals 0 to 64, and this allowed that new gap to come in and be covered. In addition to that, we were one of 40 states that received what's called a state innovation grant, and we're one of a very few that actually received a second grant. Many of you have learned about an ACO, an accountable care organization, and what those look like. What the SIMS grant allowed us to do was to work collaboratively in the community with our ACOs to align them towards quality initiatives. We have what's called VIS, it's a value index score. We're actually monitoring our ACOs on quality indicators on health, which is very unusual. Most of you know we pretty much manage through claims management. This actually is a piece of software that actually will measure things like obesity, asthma, COPD. Are our accountable care organizations making a difference in those? And that's very, very important, because then we go to what's called a value-based purchasing contract. I don't know if you know what those are, but those are at-risk contracts. Again, I know you're second year, so I apologize if there's things that I'm just reviewing for you. But all of these things are very, very important as we fast forward to where we are today. The Iowa Health and Wellness Plan, again, I talked about that as Medicaid expansion. An income of 133%. And that's really important as we move forward with this. I just go through this. Talked about SIM. It's a $43.1 million grant. So it's not a very small grant at all. It's a very large grant for our state. We have partnerships. I think we've involved several community leaders in this as well. Population health improvement, care coordination, community-based improvement. You'll hear through the Iowa Department of Public Health what's called a C3 community. Different than a blue zone. A C3 community is coming alongside us, Medicaid, and looking at actually city councils. They're looking at the YMCAs. How can they improve population health? That's a big buzzword, but what does that mean? I measure asthma. How do I know asthma makes an improvement? Well, do we go in and mitigate mold in low-income housing? Because if I mitigate a house with mold, that individual doesn't show up in our emergency rooms. That child's asthma gets controlled. That's a population health strategy, is what we're doing in those communities. Key to some of these are also like, I just lost myself. Key to those are things like transportation. If I can't get to my health care visit, how am I going to manage my health? How do I get that person to that visit? Part of the SIMS and the Iowa Health and Wellness, which makes them both very good for us, is also on the Iowa Health and Wellness Plan, we have health risk assessments. If our members actually take a health risk assessment, just ask about 25, 30 questions on your health, and they do a physical, then they don't have to pay a premium. For the first time in our state, the Iowa Health and Wellness Plan created a premium for our members to pay, and they actually had to have some risk in their health care. But if they do their evaluation, if they do their physical, they don't have to pay their premium. It's an incentive. And what that data is telling us about our population. What's the chronicity of that population? What are some of the diagnoses that we're seeing in our population? And we're partnering both of those with what we're also tracking in on our SIMS grant. Those are the groundwork, or the beginning groundwork, that actually occurred in the SIMS grant. The other thing is care coordination. The ACOs were incentivized pre-Iowa Health and Managed Care to actually build care coordination teams and actually look at wrapping around care. You'll hear us talk about integrated health homes and health homes. We actually have two, which are very important. And all of these strategies are leading to one path, and that is the path to where we are today. Statewide alert system. This is very important for us. We launched this about a year ago. It's called the SWAN. You may hear this. What happens is we know in our population we have individuals that are hopping between providers. If I'm told that I can't get a service or I can't get a specific medication, I can just show up in an emergency room and I can get it. Well, that increases cost. That's not good care coordination. Our care coordinators don't know what's happening to you, and we want to manage your care. The SWAN is an alert notification that goes out to the HEN, which is the Health Information Technology Network, that allows all of the providers to receive an alert in their emergency room when they're enrolled that says your member that's been hooked to your care coordinator just showed up in a different hospital, and they showed up for these reasons. You now need outreach with your care coordinators and find out what's going on with that member. And again, we're moving towards population health management. These types of strategies are what are allowing Medicaid to get there. It is also exciting for hospitals. If you can imagine, in their emergency room, there's common individuals that show up and continually hop between these services. We're really able to get care coordination around them and see what really is going on and seeing what's causing them to do that. So this SWAN coming in actually adds that next layer to the stool, if you will, in terms of care coordination, the community C3s, which we've just started, and we're getting ready to launch a few more. We're in conversations with Wellmark on our C3 communities, because how do we partner C3s with blue zones? Because if blue zones are looking at water quality, bike paths, walking buses, how do we partner those initiatives to some of these healthcare initiatives that we're looking at? So we're not reinventing it. So I'm giving you a really big picture of where we're headed with Medicaid, which is probably more than just managed care and how it all ties together, because this is healthcare delivery reform. And this is why this job is so exciting, if you can get away from the trees some days to see where this forest is headed. Community-based performance improvement. We're also working with Wellmark because they're actually ahead of us a little bit in blue zones. What should be those community-based improvements that we should see? What are those benchmarks? Because if we can improve transportation, if we can make sure kids get meals at lunch, and we can make sure that diabetics get to their clinic visits, then we've actually lowered the cost of health care and reduce the expenses of Medicaid and provide better quality. And actually people can go to work, they can eat, and their children can learn. And so that's kind of the global picture of where we're headed with the SIMS innovation models. We just received a meeting with Dr. Cha, who is a national expert that actually came out to Iowa, because we are further along in trying to put what I would call all these pieces together in a strategy that aligns. One that we haven't tied yet, which would tie to our partnerships with Des Moines University, is workforce shortage. Because with everything we're doing, we've got a major shortage in workforce in the healthcare arena, and we know that. Iowa Health Link, managed care. Again, things that we're working on there is improving quality and access to care, promoting accessibility, and we want patients to have outcomes, but we also want them to be accountable for their care. You and I go to the doctor, we manage our health care. These are members, and on my background, which really helps, is I come from a provider background, I come from a safety net background. Many of our families, the number one thing, they're not worried about their health. They're worried about where to get their next meal, how to get the gas in the car, and how can I go to work. We need to figure out how to make them accountable in their environment. And so that's one of the goals with managed care. And then we create a more predictable and sustainable budget for the Medicaid department. So what is in it? Everything but the kitchen sink today. Physical, behavioral health, and long-term health are now joined together. Whole person orientation. Most managed care across the nation have not moved the long-term services and supports, the nursing homes, the waivers, supported community living. We moved it all in on April 1st. We have 3 partners in this, AmeriHealth, AmeriGroup, and United. And most Iowa Medicaid waivers are included in this, but not all of them. The majority of our waivers, which is a waiver, we have waivers for elderly, behavioral health, and ID. The goal of our waivers is to keep people home. And so a waiver is basically a waiver so they're not in an institutional care environment. Who's it included? You can see that we have almost everything. It's probably easier to say who's actually in fee-for-service, because don't forget, we left a small portion, about 55,000 members, outside of managed care. That's the Native American and Alaska Natives have an option. We have a program called HIP. Don't you love all these acronyms? I don't know how they almost all rhyme, but they kind of do. And that's the health information. And what that is, that HIP program is for families that have insurance. The state found out that it's cheaper for us to pay their premium and keep them in their private insurance than to put them in the Medicaid program. So they're actually excluded from this program, and they stay within our fee-for-service model as well. Medically needy, what that is that is an individual that's determined that they are medically needy for Medicaid, but they're not enrolled in managed care. They continue to be in fee-for-service for us. Undocumented are not in this program and not in managed care. And what we call presumptive eligible, someone shows up in a hospital or in a setting, a clinic setting, and we presume that they are eligible, which means they meet all the criteria, but they may not have all the information that we can actually enroll them. We will presume them eligible, provide the care they need immediately, and then wait for the enrollment. And if they are enrolled and do qualify for managed care, we move them into the managed care environment. But this allows us to provide care to that individual without that individual not receiving the services that they need and not the provider not being paid for those. So those are some of the programs that we actually, and then PACE. PACE is another new program, and that is the program for all exclusive elder care. You'll start reading a lot about PACE centers. What's happening in our nation is growing old. The nation's getting older. There is, not news to you guys, and one of the goals of this program, it's almost like a clinic for the elderly, and it has care coordination in it, it has adult day activities in it, it has health care coaches and mentors in it, and it has a way of just taking people who are 55 and older into an all-inclusive clinic and managing PACE. The question for us now is, do we move PACE into managed care? And those are things that we are continually evaluating, because again, it was created at a time when we didn't have managed care. Does it make sense to move that population, just like we're moving our ACOs underneath the managed care umbrella, so we have one system of care? In terms of updates, goals for this, I got that one. Hang on. This is okay. So one is increased care coordination. Here's what's really important in terms of the Iowa Health and Link. Nursing homes. Everybody in a nursing home now has a case manager. They didn't before. What's the number one reason that people go to nursing homes? They can't manage their care at home. Our job is to try to keep them out of the nursing homes, keep them with their families, get the home care support that they need. If they're in a nursing home, and I just learned this the other day, there are several individuals that are on our waivers that go into nursing homes in the winter because they don't want to deal with everything at home and they want warm meals, and then they come back out in the spring. Interesting concept, but it works. And our job with the care coordination is how to move them appropriately to keep them healthy and keep them viable. Primary care physicians, every member is assigned a key primary care physician. Value-added services, the Medicaid budget grew almost in the last 10 years, has almost doubled herself. The budget's not sustainable in its current meeting. But there's so many other services that are needed to keep these individuals healthy. Weight loss management, maternity programs. We actually have one of our ACOs that if the mom gets all the maternity payments, they get gift cards for gas, or they get gift cards for clothing. They'll go in and actually have told stories where they actually put a driveway in somebody's home because they could back the car out and get the car to the appointment. It's cheaper for them to do those kind of value-add services than for us to continue to struggle for some of the reasons that we would not be able to do those. The other thing that we found is that it's trying to make this Medicaid sustainable, reducing duplication of services. I gave you an example earlier of people moving between hospitals, moving between clinics, duplication of services. There's often times when members will get a lab done in one hospital, go to their doctor, and they'll repeat it. You guys have heard these stories. Or they go to home care and they get it done. How can we eliminate that? Shift away from what we call pay and chase, which is what happens is that Medicaid was paying on the front end almost everything when you came in. The MCOs will prior auth it, and they'll make sure that if you have a third-party insurance like Medicare or Wellmark, that you pay your premiums first, and then Medicaid is secondary. It's kind of flipping the state. In the past, it was Medicaid and then everything else last. That actually, if you can collect it on the front end, is a lot better from the state from a budgetary standpoint. And then also prevention and early detection. How do we get health risk assessments with the elderly? How do we do early diagnosis? How do we encourage physicals? And how do we actually make health a life choice? And that's where we're moving with the managed care initiatives. Members continue to receive services, doctor appointments, and other services, arrange non-emergency transport. Iowa is one of the states that received actually a waiver for this, so that we could actually provide transportation to clinic visits. Because again, like I said, getting to the doctor is the number one issue for us. And then a large number of them are already using value-added services. We've paid over 3.4 million claims to Iowa Medicaid providers from April to June of this year. And the claims are paid an average of 8.5 days. Medicaid was paying approximately about 6-7 days. So we're real close to being actually paid. What we're learning about paid claims and what we're worrying about managed care is our providers weren't as sophisticated as we thought they were, especially the long-term services and supports. In terms of understanding when we move to managed care, we're all using the same form, but don't know what a national NPI number is. That's the Social Security number for the provider. Knowing what that is, knowing that you can't use a P.O. box. We moved all of our claims to electronic. A lot of our long-term services and supports paid paper. So that's a huge, and you've read in the paper, providers aren't getting paid. The number one reason, a lot of it, is because of the fact they didn't know how to fill the form out correctly, or they were paper and they would put it in the mail and it would come. Well, Medicaid could move towards that. We're now moved towards automation, and that has slowed down our ability. So what we have done is wrapped ourselves around our providers, have intensive training. They also have what's called a clearinghouse. So when you and I do a bill and you send it in, there's actually a clearinghouse that will screen it for any kind of HIPAA violation. Those kind of things. Our providers didn't realize that those clearinghouses provide batch reports to them to say what happened to their claims. And it's just a big, huge learning curve. And if we can step back and realize that not only is Medicaid learning, our providers are learning, we can get there. Things like we've had MCOs drive to the providers and sit down with them and do billing trainings and actually help them with electronic fund transfers. Most of you are so automated that wouldn't make any sense to you, but a lot of our providers were paying checks. Well, electronic fund transfers come in 2 days. A check takes 7 days. So we're actually moving our provider healthcare delivery system to a more sophisticated level in terms of automation and real cash flow for our providers. So this is exciting, even though some days it's very hard for them. When you're used to getting paid first for Medicaid and then turning and getting paid for Medicare, and we've just flipped it, imagine that. That's a 60-day turn on your cash. So if you and I were going to go buy a new car and you have a budget, it says when you pay your bills, and all of a sudden that car comes before the house payment, you have to shift your billing. Imagine if you are actually a business and somebody flips it on you. You got about a 60-day turn on cash. So how can we help them understand that, and how can we train this? This transition, the billing transition, is going better than we anticipated. We do have providers in long-term services that are challenged. We've also added to this what's called a provider liaison, and that's an emergent staff member that actually goes out with the MCOs and works directly with those providers that are having those issues. Members enrollment assistance and choice counseling. Key to this is really actually very good in that when someone enrolls with the Iowa Health Link plan, they actually have a choice of 3 providers. They can make the choice. How do they know? They can call our member services. We'll walk them through them. We continue determining if they're eligible for the program, but they can pick between AmeriHealth, AmeriGroup, and United. We provide them information. Matt Hyland, our communications, has done an outstanding job in really making that easy and learnable for our members so they can actually make an educated choice in terms of which network they want to be in. Provider outreach and enrollment. We're doing extensive enrollment and outreach activities. And then key to this whole entire managed care initiative is oversight and contract compliance. And this is very important for the state. It's very important for us because we just have about almost $4 billion in contracts that we have to make sure that they are actually meeting the requirements that we had actually put in the state's RFP, which is a request for proposal for this program. So performance measures are driven by oversight. Objectives, members are safe and they're getting the services that they need. That's our number one perspective. You keep the member in your sights at all time and make sure our members are safe and they get what they need, and that providers are receiving timely payment. If providers don't get paid, they won't see people. So we need to make sure those happen, and that the program is well managed and the goals are achieved. And then contract compliance, we closely monitor that to ensure the program. Our contract for managed care is on our website. So you want to see that, the RFP. You can see that when we built our RFP, we reached out to a whole host of states across the United States, listened to what they did well, listened to where they had hiccups, and built them in the RFP in terms of oversight and compliance. DHS, we have data reporting requirements. Again, they have to meet the federal guidelines, the state guidelines, and our contract requirements. It's collected and reported daily, monthly, quarterly, semi-annually, and an annual basis. Unlike most states right now, we are doing monthly reports on where we're at in terms of demographics. We're looking at how members are choosing and are they moving from one MCO to the next. Surprise to us was within 1 month of the program, and now within the first quarter of a program, 75% of our long-term services and supports have moved to one MCO. What does that mean? They better be moving on care coordination. They better be moving on some different services for that. We did not anticipate that our members would choose to shift 75% of a market in a quarter. And that has created some opportunities for us and for them. And then we also will be submitting other entities, will be on MCOs. And then DHS will utilize dashboards. If you want to see our dashboards, the monthly reports for both April and May are on the website right now. It takes us about a 45-day turn when we get the data in, and then it takes us to analyze it and then to turn that data out. The monthly reports will be looking at very basic things for you, demographics, as I said, but then in addition, we're looking at prior authorizations. That's critical. So if somebody comes in and you have to have a prior auth for a service, how quickly are those MCOs turning that prior authorization for you to get that service? Are claims being paid? Some of these, what we call key indicators to ensure where we are at with the program, are in our monthly reports. We are just now putting together our quarterly report, and there's like over 44 reports that had to come in for that report. So it should be coming out in early September, somewhere in that time period. That actually has all of our quality matrices in it and monitoring of quality systems for our programs. Remedies, guess what? If you don't turn in what you need, we actually do have remedies for compliance. The first time we give you a written warning that says we did not receive your data timely, or we did not receive your data that is actually clean. And then we actually can move to liquidated damages. We can withhold part of the capitation payments, suspend auto-assignment, which means that you will not receive any new members till you cure yourselves, and up into including termination. So the oversight is very stringent, and we're very serious because, again, you hold a member's life in your hands, and we want you to care for them the way we want you to and the way we expect you to in our contract. This is not unlike any other state. Most states do have remedies for noncompliance at the level that we have them at. Most people don't have a remedy matrix like we've developed so that we can actually show the accountability. At this point, we have not, we instituted, or we will start remedies in August because we gave the first 60 days to where we could gather data, look at data, and look at trends. So we will start looking and reviewing reports this month. Moving forward, we'll continue to add new ways to be innovative. Like I said, we're looking at the SIM and how we pull it in. We're looking at our health information, our HIP program, our PACE programs, or finding ways to avoid fraud, waste, and abuse. We are constantly looking at, a key thing to us was billing. We spent quite a bit of time this afternoon on billing, but one key thing is the MCOs are using industry standard edits. The state of Iowa may not have all of the edits that the industries have, so what happens is if I'm a provider and I'm used to billing Medicaid one way and you bring in an MCO and they have different standards, it might deny my claims. But you know what? Maybe some of those edits are not so bad for how we should be providing services. MCOs may be bundling services. For example, a venipuncture, we actually pay you go to the doctor's office, we pay for that. We pay for the needles, we pay for the supplies, we pay for the doctors. The MCOs bundle it. Is it more efficient, more cost-effective to bundle the service? So we've literally put together an edit group, something that I don't love, but data people do, to look at claims and what's the best practice for how we bundle our services and provide those cares. Finding new ways to improve or come up with better outcomes. We have sat down with the value index score. Right now, our value index score, the MCOs are required to use it on all their contracts. The VIS scoring, but it didn't cover behavioral health. It didn't show us how do you improve behavioral health. It is the number of admissions to the ED that you avoid. Is it the fact that you've coordinated the medications the individual's on? What is the measurement for behavioral health that we can prove that has a healthy outcome that leads to healthy lifestyle? We've spent the last 3 months talking to 3M Treo, who's actually developed the software, and having them do national research. What should the benchmarks for mental health care be for us? And actually, we will start being one of the first states that will be able to measure outcomes for improvement for the behavioral health members in our community. The other is long-term services and supports. I would, do your research. You're not going to find that there's a lot of measurements on the elderly. What are we doing? Are we keeping them out of the nursing homes? Are we making sure that they have good, healthy meals? What should our indicators be for our older populations in long-term services? So we're working with them so we can have more robust. Those are innovative models that we can look at nationally and say, these are some benchmarks. The fact that Iowa literally moved in a year and actually launched a full-blown managed care in all populations, again, is very innovative and very strategic in the way in which we did it, because it's whole person orientation, moving towards population health management. You guys have questions? There's got to be questions on this. Yeah.
I want to thank you for coming. My name is Noreen O'Shane. I'm actually family medicine department, but I'm also the president of the Iowa Cabinet Clinic Physicians here.
Okay.
I really appreciate the fact that you came and gave us such good information.
Sure.
And I know it's been a headache, but I have felt the rollout has not been that bad. So
Thank you.
Congratulations to your staff.
Thanks.
My question is me wearing my other hat, which is when I'm teaching my third-year students and teaching them family medicine, and we're seeing our MCO patients. One of the requirements has been to do a physical,
Mm-hmm.
and it would be loved. What is your sense? What do you communicate to the providers? What we are supposed to do at the annual physical? Is there a sense of what the Iowa Medicaid Enterprise wants us to? Are we supposed to find things that were never discovered before because they didn't have insurance, or we're supposed to update things? Any sense of that?
I know that on the health risk assessment, under the Iowa Health and Wellness, we look at what I would call healthy outcomes. And I'm sure some of your students have done that. I would think that we're looking at, and I will go back and clarify it, we'll have Matt clarify it for me, is what specifically we are looking for, but I think it's a general, level set. Level set for me, the member that's either had a physical and are there new conditions involved, or a member that has never had a physical and we want a baseline on the condition of that member. Because you're right, there are a lot of people that have never had a physical that are in their 50s, which is amazing, but they haven't. Are their immunizations up to date? Are there are they at risk for heart disease? I would get those, what I would call a level set on that member, but we can definitely clarify that for you. That's what I would think we would be looking for. Mm-hmm. Other questions? Yes, sir.
My name is Pardeep Singh. I'm a first year DF. I just had a couple questions. You mentioned blue zone earlier in your presentation. Could you explain what that is?
Okay, so a Blue Zone was an initiative that was launched by Wellmark, and it is actually, they did research all over the nation, and Sue Huppert might know this better than I do, but one of the things that it actually did is there are certain pockets throughout the world that there are people living past their hundreds, like 125, unheard of. What are the things that they're doing? What are the healthy environments? What are the types of foods that they're eating? And communities, I believe Cedar Rapids is a Blue Zone. I think. And they actually, there's guiding principles on what it means to become a blue zone, like gardens in urban areas and eating healthy foods. And there's certain criteria for these zones that full communities have become those. Walking buses, instead of your children taking a bus, they literally have family members walk their kids in a line to school. All those healthy things is what a blue zone is designed to do in terms of making the environment a healthy environment. And then if we can partner underneath that with our initiatives on how we monitor diabetes and asthma, together we're working, rather than them strategically going out and trying to do, let's see, if they weren't doing healthy food, but we're trying to deal with school kids being hungry, if we can partner and they deal with school lunches that are healthy, and we partner with managing kids that might be predisposition to diabetes, together we could probably help ourselves together. So we've just started to talk about, with Wellmark, how do we align our C3 communities with what are existing blue zones right now.
I have another question.
Sure.
You mentioned that 75% of the islands were insured moved to one managed care.
Mm-hmm.
Which one was that?
So they all move, for long-term services and supports, a lot of them move to AmeriHealth, Claritas, and I can tell you why. In our design for the Iowa HealthLink program, we require managed care. We require community-based case management. We want every member to have a case manager. It's going to monitor, because remember, our members are worried about food, they're worried about transportation, and they're worried about gas. I mean, I'm not worried about my physical right now. I'm seriously worried about if I'm going to be able to feed my family. We wanted them to have a community-based care manager that would call them and say, you know what, you forgot this. We really want you to get this done. How can we help you? And so AmeriHealth Claritas hired the local community-based case management so those members could keep the management that they had with their the relationship with their care manager that they had. Now they're going to be changing what their requirements are for those care managers, but that's why the shift moved, is because they decided to actually hire all the community-based case managers rather than utilize outside sources from the state, which the other two MCOs did. Yeah. Yes, sir.
I had a question. So you talked about the various metrics that Medicaid is managing or looking at for various MCOs. We're just wondering if patient satisfaction and provider satisfaction with those plans are part of those metrics and are kind of taken into account.
Yep. A couple things we're doing there. And again, Matt has been instrumental. One is when we hear on all call centers, we have three of our own call centers. The MCOs have a provider member call center. We secret shop on those. We are only looking for, do you have the technical knowledge, which we found in some of them that they had to learn Iowa a little bit. But we're also looking for soft skills. I mean, this is a major transition. You're dealing with people's lives. You know, if I don't know which one to pick, you need to help me understand it, not be abrupt and say, well, can't you just figure it out? I mean, we watch for those things, and then we go back and we talk to those members. So we secret shop every one of them. The other thing we do is we watch for trends, so that if members don't know something, we script them. We script not only our call centers, but we script all the MCOs' call centers, because we know that if you hear something once, you're not going to pay attention to it. But if you're hearing it from 4 different avenues, you might actually be able to get it and understand it. Same way with providers. You know, this is a huge business shift. This is for the larger healthcare systems. They've been dealing with third-party administration. But for anybody that's outside of behavioral health, because remember, behavioral health in our state was managed by Magellan for almost 20 years. But these nursing homes, the CDAC provider, which is a community-based provider, and even our nursing facilities are not accustomed to a high degree of managed care. This is a huge transition. I gave you an example of how their cash flows could even be impacted. Are those call centers talking to them? Is our escalated billing executive showing the kind of compassion and education that they need for these providers? Because one size isn't fitting all. It's very much custom to individuality, and we then ask for feedback from the providers. And sometimes, quite honestly, the feedback isn't exactly pleasant, but that's okay, because it only makes it better. If everything was wonderful, we would probably wonder what we're doing, because we would want that feedback. You're exactly right. Yeah.
Mikki, you mentioned early on the workforce shortage and a possible ways to partner with one university. You have
looking into your crystal ball and knowing what's coming, can you tell us what you see so that they are prepared? So a couple things, thank you. A couple things that we're looking for is when we moved managed care in, and this was a major concern in our state, we already have a workforce shortage on care coordinators, or what we call frontline staff. It doesn't mean that they're not important, because those caregivers are twice as important as a whole other continuum of individuals. But when those MCOs landed, everybody was really concerned that they were going to pull everybody out of a lot of the systems. If you talk to some of the healthcare systems, they did lose nurses. They lost frontline staff. They actually lost some of the physicians as well to managed care organizations. These organizations, as we look towards that, key to us will be, what are we doing in the arena of behavioral health? We already have a shortfall of behavioral health professionals. What are we doing with the MCOs in their value-added strategic initiatives to say, how do we identify where we have network shortages? So, for example, and one of the things that we had to do for CMS to be certified is we actually had to do network adequacy analytics. And we know in our state where we don't have primary care providers, where we have mostly physician's assistants. We know where we don't have specialty physicians in terms of neurology. Where are those pockets, and what do we need to start looking at strategically? One of the things that the MCOs can bring to us are resources. We know in our healthcare delivery system, especially in behavioral health and even in some of our children's programs, we go from acute to nothing. And I mean, we need to have a step down, a transition. We have PMICs, but most of our PMICs are children's mental health clinics or centers. They're out of state. So we don't have what we need. We're looking at our MCOs to say, help us understand, with all your care coordination, where are we identifying either new delivery systems we need to build, new provider systems we need to help create, and where are we going to get the workforce to do that? Now, keep in mind, we've only been live 100 days, so this strategy is on the table, and we're talking about it, but we're building that work plan. And so actually getting demographics of where physicians are, where the residents are, how do we keep providers in our state. One of the value adds of the MCOs was their wages were substantially, in some cases, higher on the front end than a lot of the other, like nursing homes and care coordination. But unfortunately, that also pulled and created a little bit of suction in the market, if you will, on those frontline staff. So then how do we create that so they don't all flood into the MCOs arena? So that's what we're starting to talk about, and probably we'll have more conversations when we look at that, because I know we really want to understand if our system, if you were to put Medicaid with Wellmark, we have 98% of the insured in this state between the two entities. So we cover a big mass. So how do we together look at some of those through the SIMS grant to allow us the innovation we need to move forward? Yes, ma'am. To be honest, we haven't looked at the shortage piece for you, but what we have looked at is members receiving the prenatal care. And there is definitely, in this population, a gap, and they will wait. And so what is it that we can do, which is, to your point, going to add to shortages for those types of providers to help us, is that what do we need to try to educate these moms that getting prenatal care, what are some of the incentives that the MCOs can do? And how can we incentivize the MCOs? I know that in our capitation payments, we give them what's called a kick payment, so that we hold back some of our cap payment to the MCOs until that mom's actually had the delivery and level of care that we want them to have. And then when that baby is born, we actually will give them back the rest of that cap payment. So we're really trying to work on the preventive side with the member to really try to get the mom educated that it is imperative to show up for those visits. I know that you can see that AmeriGroup, I believe, opened a new clinic with care management in it, and that's one of their initiatives, is really trying to work with pregnant women that are not seeking out prenatal care until they're like almost in their 6th month, which is, you really need to get it within the first 3 months, and we're trying to figure out how to get that. The other thing we're watching is immunizations on our children. They move into the program, are they getting the immunizations? And lo and behold, are they getting dental care? Because that's also a big thing for our kids. And what are they doing for that? Most of you in this room probably don't realize that we expanded Medicaid dental care to a second carrier August 1st. So we now have two, MCNA and Delta Dental. So when we're talking managed care, we're not just talking medical. We're talking whole person, including the dental programs. Does that help answer your question? Okay. Other questions? Yes, ma'am.
I have a question about the case managers that you talked about. About how many patients does each case manager have in its relationship? More that if the patients have a problem or a barrier that they'd like to address, that they talk to the manager, or is the manager actively speaking to each of their patients and trying to troubleshoot?
I'm not quite sure. Is it a 1 to 54?
We do have a case management ratio that's going to be published quarterly.
Okay, so I don't have that yet, but he'll have it. Yeah. It's coming. So what they do, you actually have a couple layers, believe it or not. In our long-term services and supports, it's actually wrapping around that member. In long-term services and supports, it isn't just elderly. It's ID, intensive children with high-risk needs. It's individuals that are intellectually disabled with behavioral health. That's long-term care, because those are chronically ill individuals that need a full-blown wraparound service. That care manager literally does staffings with the mom, the MCO, the dad, whoever that support system is with that member. It could be as frequently as daily on some of our members. It could go as long as maybe a month, depending upon how well they do. So we have that care coordination, and then the MCO on top of that has a layer of care coordination to look at utilization management and really oversee some of that care that that member's getting and saying, have you thought of this type of care versus this type of care, depending on the member's condition? Again, to one, think about high-quality care to that individual, and two, what is fiscally sound and stable for that family and that member. So we have multiple layers. Then to add to that, we also have the health homes. And the health homes are designated with primary care providers to look like we have a chronic health home that is dedicated to diabetes, congestive heart failure. Those are the two right now that are coming to pop. And they actually wrap around members that have those chronic conditions. And then we have integrated health homes that are specializing in behavioral health but connecting to primary care. Because we know a lot of our behavioral health members aren't actually getting the physicals they need and not paying attention to their medical conditions, then that just spirals those. So it's a huge, complex web of care coordination that is wrapped around the members and trying to move them and trying to help them. Yes, sir.
Could you speak a little bit more to the childhood immunizations
Key to that is working with the Iowa Department of Public Health, and you'll see it, and I think we'll report this out also in reports, is actually looking at, and also in managed care is the Hawkeye program, which is a third-party administered program. So again, it's everything in this bucket. And looking at if we have people that are not qualified for Hawkeye in Medicaid, and those that are in our Hawkeye program, if we line the analytics, how are the immunizations? Are they better in the managed care environment, or are they better in the Hawkeye program? And we really want to monitor that, and then what's the difference, so that we can align those programs for better incentives. Yes, ma'am.
My question is about, you mentioned both population-based support as well as most value-added initiatives. I was wondering who makes the recommendations about developing this program, and how are the MCOs?
So the MCOs bring on board a full-blown of value-added services when they came in and with their contracts. And they said, we want to offer all these based upon their national contracts. In fact, this afternoon we're meeting with the MCOs specifically and looking at PMICs and knowing that we have this continuum gap where we're saying that we can't coordinate care because there's nothing to coordinate to. We can sit down with them and say, if you have value added, can you direct or help us direct to resolve an issue in our systems? And that's through those dialogues and those negotiations with the MCOs that we start directing them in terms of some other key strategic value add services that we want to see in our communities. But a lot of them have brought them in, knowing that, for example, if I get you a health risk assessment and you need to exercise, well, if I don't give you a gym membership, you're not going to do it. So if I give you a gym membership and the care coordinator asks how's it going, chances are you might be going to the gym because you've got accountabilities. So they kind of know how to tie those together, and so that's the kind of services they're bringing online. It's collaborative. I mean, a lot of them will bring their national trend and their national data to us, and then based on some of the experience we have in the state, we actually say that might be good, but we've got more of a problem over here. We'd want to try to connect this one first, and then maybe do this one. We kind of are. I mean, we're kind of collaborative on that one. Yeah. Yes, ma'am.
Is there a population of people that you're finding is particularly hard to reach or remaining medically underserved, even with the population health goals?
That would be the whole Medicaid population, because part of the problem with them, and I mean, all joking aside, it's a very transit population. We actually have a lower return rate on our mail, but they are hard. I mean, they move a lot. And then they'll come in and out of Medicaid. We call it churning. They'll come off the program, go back on the program. So one of the things that we have to do working with the MCOs is really keep the data. So if you come in and off of, for example, I know the statistic because I was looking at it this morning, for dental care, we have 38% of our dental enrollees that come off the program and back on in a year. That's almost 50% of the whole entire population. So we have to do something. We can't just say it's okay, because then you lose their checks, you lose anything we've done for them, you lose unless we hang on to it. The same thing happens in Medicaid. They come off and they go on and they come off. We're really trying to keep them, even if they move around with the care coordination, keeping them connected to us so we can get them the service. But this population is very transient and it moves an awful lot. It's not uncommon. Nationally, this is the type of population that moves. Good question. Yes.
What is the integration with providers and physicians in terms of all of this?
Yep.
Because it seems like obviously the insurance, MCOs, and administrative are collaborating, but to make sure providers are misunderstood.
There's a couple. We actually have 3 layers that I can think of. In pharmacy, we have what's called a preferred drug list. We also have a drug utilization review committee. That's made up mostly physicians and clinicians that come in. We have mandated the MCOs use our PDL, and so sitting down with those doctors are what are some of the new pharmaceuticals coming online. We know that hepatitis C medications are coming online, and they're very expensive. So what does that drug utilization review committee do? They talk to the providers. On Hawkeye, we have what's called a clinical advisory committee dedicated to kids, and that has our chief medical officer and then clinicians throughout the community that sit on our clinical advisory committee, and we have a mirrored one for the adult population as well. So we get feedback for clinical and quality for those 3 committees, and what we're in the process of doing is rolling them up into a quality council, if you will, with the MCOs at the table with us. Probably any other questions? You guys have been great, and I appreciate the time. Thank you so much.
Okay, thank you everyone for coming, and thank you so much, Ms. Stier, for taking the time out to come and have this wonderful discussion with us. Don't forget to badge in, and then if you guys have any other questions, feel free to let us know. Oh, and our next event is Governor Branstad, who's coming the 22nd. So please mark your calendars for that and come hear about the initiatives that he's supporting for healthcare in the state. Thank you.